So now let's turn our attention to metastatic melanoma. And I'm going to ask my colleague, Omid Hamid, to lead a discussion about the role of these checkpoint inhibitors in the management of this disease. So Omid, can you tell us a little bit about the current status of these molecules?
Great. No discussion can go forward without beginning by talking about the initial checkpoint inhibitor, ipilimumab. We know that in 2 randomized phase 3 trials, ipilimumab showed survival advantage, a 4 months overall survival advantage, and recent data from long-term survival shows a 20% 10-year survival. That's 10% better at certain points. Now with the PD-1, PD-L1 targeted agents, we're finding the similar things, but possibly in a better fashion. One of the issues with anti-CTLA-4 therapy was the low response rates, somewhere between 10 to 15%. With the anti-PD-1 and PD-L1s, we're seeing response rates somewhere between 30 and 50%. Similar to the ipilimumab responses, these responses are durable. We've presented data with nivolumab and with pembrolizumab, formerly called MK3475, that there is the patients who respond, 88 to 90% of them continue to respond at 1 year. That's wonderful. A higher response rate and a durable response rate. On the other side, the concern about toxicity has been somewhat alleviated. The major toxicities that we see with these targeted agents are not the colitis that we've come to know with anti-CTLA-4 therapy. In fact, the major toxicity is a pneumonitis, which mostly is asymptomatic and can present with cough. That incidence is less than 5%. As we've moved forward, we've understood that these patients can be repeatedly dosed, and while they're dosed, if a immune-related event occurs, we can hold and with resolution try and redose these patients. And that's moved us further than before. What I mean by that is the low toxicity, the tolerability has allowed us to move to the next step, which is building from the benefits that we've gotten from these PD-1, PD-L1 antibodies, and that's combination therapy. Dr. Marius-Knoll will present data, and it's with the anti-CTLA-4 antibody and the PD-1 antibody from Bristol. Mm-hmm. And this data has shown high response rates, deep responses, which means patients with high volume disease have shrinkage below 80% of the mass, so 80% of the mass shrinks.
At least 80% responses.
At least. Yeah. And they presented data with long-term survivals, 1 to 2 years over 80%. Now these trials are small trials. For example, the pembrolizumab data presented at ASCO was in over 400 patients. But what these trials have allowed us to do is accrue over 2,000 patients to randomized phase 3 trials, which have accrued, and we're just waiting for the data. Randomized in first line and in second line to evaluate the benefits of combination versus single agent versus anti-CTLA-4 therapy. ASCO 2014 has also shown that these agents can be combined with other immunotherapies. A interesting immunotherapy is oncolytic immunotherapy with a oncolytic virus with TVEC. And in single agent studies, TVEC has shown a progression-free survival advantage. And with combinations, we have seen interesting data. Data presented at ASCO with TVEC and ipilimumab combination in 18 patients showed no significant adverse events and a response rate of 56%. That's going forward in a randomized study of TVEC and ipilimumab versus ipilimumab alone, and is already spurred a trial of TVEC and pembrolizumab versus pembrolizumab alone.
Can I ask a question about that? So we're talking about two very different but potentially complementary strategies here, aren't we? In one case, you're trying to release the brakes of the immune system, which is what you're doing when you use a checkpoint inhibitor. And you're allowing the immune system to go out and recognize tumors and destroy them, presumably because there's antigens on the tumors that are being recognized, right? Now, with the TVEC approach, what you're doing is you're actually providing greater impetus to develop an antigen-specific immune response.
Right.
So do you think that this is also going to be useful for other vaccine strategies? And how do you reconcile that with the fact that the original studies of ipilimumab, which were done in conjunction with peptide vaccines, didn't really show much of a added benefit for the use of the peptide vaccines?
Absolutely. That's a question that we're going to try and figure out, because that same peptide, when combined with interleukin-2, showed higher response rate. Doug Schwarzentrooper presented that. I think we don't understand fully who responds and how they respond. And predictive markers, we'll touch on later, will help us find that. At this point, it's all open and on the table. ASCO presented multiple strategies for combination, whether it's with a IDO inhibitor and a checkpoint inhibitor has been presented, whether it's with oncolytic therapy and a checkpoint inhibitor, whether it's dual checkpoint inhibition. And the future in our clinics will have the ability to have T-cell agonists and checkpoint inhibitors going forward. So I look forward to that, and the question of whether it's truly beneficial to combine these therapies or sequentially give these therapies.
I'm going to ask